Bueno, tenemos ahora una conferencia extraordinaria sobre cómo le va a los niños con displasia broncopulmonar en su neurodesarrollo. Es sabido que los niños que padecen displasia broncopulmonar siendo prematuros tienen mayor riesgo y tienen un comportamiento diferente. Así que agradezco a Aleid, y mi compañera de mesa les va a contar quién es y el honor que tenemos de tenerla como profesora en este congreso y en este momento. Gracias, Aleid. Vamos a presentarla.
La doctora Aleid Leemhuis es pediatra neonatóloga del Centro Médico Universitario de Ámsterdam, del Hospital de Niños EMA. Además, profesor asociado y jefe clínica de seguimiento ambulatorio, expresidente de la Sociedad Holandesa de Seguimiento del 2003 al 2013, profesor adjunto del New York Medical College, consultor de expertos en el apoyo del desarrollo post-alta. Forma parte del grupo de expertos de seguimiento de la Fundación Europea para Cuidado de Neonatos y Lactantes, EFNI, y además es miembro del Comité Científico Asesor y apoya en proyectos de investigación en Países Bajos. Bienvenida, doctora, y estaremos atentos a su conferencia.
Then I'll start. So please let me start with thanking the organizers for the opportunity to present data on BPD and long-term outcomes. Especially, I would like to thank my friend and colleague Lydia Gioducci. In Amsterdam, our NICU focuses on two topics, especially in research, that is improving pulmonary care and long-term outcomes of very preterm infants. And in the topic of my talk, I now can share some of our results on these two topics, focusing on long-term outcomes. When discussing the role of bronchopulmonary dysplasia in relation to neurodevelopmental outcomes, it is important to first address the context and look at a wider picture of neonatal risk factors. Gestational age itself remains the foremost risk factor for worst neurodevelopmental outcome because of the associated immaturity of the organs and systems. The longer the time spent ex utero, the higher the vulnerability to encounter other perinatal risk factors. Second, growth in and ex utero is a risk factor, whereas good nutrition and breast milk are protective factors ex utero. But then third, we encounter the topic of today, bronchopulmonary dysplasia, that is high of the list of risk factors. Additionally, there is risk factors are neonatal infections and higher stages of neck and brain damage. And most difficult to sift through is the last one, the interaction of all of these multiple risk factors, in which socio-demographic and household factors also play an important role. I just do a step aside to stress the risk factor, the first risk factor on my previous list, that is gestational age. And I just wanted to show you here the result from our most recent paper that was done by data linkage in 1.8 million Dutch children aged 12. While in the comparison group of children born at 40 weeks gestational age, special education is used in about 5% in our country, the upward trend towards lower gestational age is very visible, and this underlines the magnitude of the risk factor gestational age. But now back to the topic bronchopulmonary dysplasia. As you can see on this slide, scarring of the pulmonary tissue down the preterm neonate. Risk factors are fetal and neonatal, and especially inflammatory state, fetal neonatal growth restriction, fluid overload and oxygen toxicity, and barotrauma. Via several cellular mechanisms, deficient alveolarization and vascularization, and altered growth and oxidative stress and increased matrix remodeling can take place. And these factors result in impaired lung growth, function, and repair. On this slide, you can see how the risk factors inflammation on the prenatal period and in the postnatal period are put together. In the prenatal period, apart from placental insufficiency and impaired vascular development, chorioamnionitis increases the risk, the vulnerability of the fetal pulmonary system. And then in the neonatal pulmonary system, you can see that the balance goes towards red, towards severe BPD, if there is inflammation and also oxygen and barotrauma. But you can also see the protective factors, breast milk, a favorable microbiome, caffeine, and perhaps postnatal steroids. Much has been written about bronchopulmonary dysplasia criteria. And for international comparison, it is best as everybody uses the same criteria. They needed and they still need to be updated with change of neonatal care, which was done by Job and Bancalari, for example, in 2002. When this a neonate meets the criteria of bronchopulmonary dysplasia, a neonate is diagnosed with BPD when the days on supplemental oxygen during the neonatal phase are more than 28. And then, if the child is born at less than 32 weeks gestational age, the diagnosis of BPD is made at 36 weeks postmenstrual age. Now, with the higher use of heated, humidified, high-flow nasal cannula, this is the classification that nowadays is used by most people. And I just focus now on the children born before 32 weeks, because that is the group in which BPD is most prevalent. You can read also the criteria for the other infants in this column. If at 36 weeks PMA, the infant is breathing room air, the diagnosis, and previously it had oxygen needed for more than 28 days, then the diagnosis mild BPD is made. But if there is need for supplemental oxygen at the 36 weeks postmenstrual age, then we speak of moderate BPD. And severe BPD is there when there is ventilation or nasal CPAP or high flow needed at more than 1 liter per minute. Can BPD be prevented by neonatal treatments? of course, that is possible to some extent. In one of my previous slides, the good effects thereupon of caffeine was shown. And here I show you a slide from the famous CAP trial, an RCT initiated in Canada that ran in many countries over the world, and where we in Amsterdam also participated. As you can see on this slide, the only neonatal outcome that was positively affected by the use of caffeine was BPD. It occurred in 36% of the children treated with caffeine and 47% in the placebo group. There are no studies that looked at the consequences of caffeine via BPD on neurodevelopment. But in the total study groups, 1,000 versus 1,000, at the age of 5, there were no differences in developmental outcome between the caffeine and control group, despite of this lower incidence of BPD. And at age 11, these children were followed up again, but it was a smaller group of children. Only the visual motor index was better in caffeine treated in children, but all other developmental outcomes that were assessed were similar in both groups. On this slide, the recommendations done by a systemic review in JAMA are shown on the topic of BPD prevention. These authors suggested delivery room continuous airway pressure and withholding of more aggressive approach, early on non-invasive surfactants, early hydrocortisone prophylaxis, inhaled steroids, and volume targeted ventilation in those neonates needing ventilation as strategies that may decrease the combined risk of BPD or mortality at 30 weeks postmenstrual age if used in a multi-pronged approach. But in their wording, they use the word may decrease, elucidating how difficult the prevention of BPD is. The famous French national cohort study, EPIPAGE, and this was the second version of the EPIPAGE, studied outcome at age 5 in detail. In a secondary study, they split up their cohort in those with and without BPD. BPD had a wide definition that was not the same as the classification I just showed you, and thus also included mild, moderate, and severe cases. It was defined as any respiratory support, including invasive or non-invasive ventilation or supplemental oxygen at 30 weeks postmenstrual age. Nevertheless, these authors showed a strong association between BPD, I lost my slide, between BPD and neurodevelopment in their cohorts below 31 weeks gestational age. And first they showed that BPD was more prevalent in children of lower gestational age. And on the right, more complex slide, you can see that in these two columns, almost all developmental outcomes, neurodevelopmental impairments, developmental coordination disorder, behavioral difficulties, IQ, CP, autism, all occurred more frequent in those with BPD. In Amsterdam, we studied neurodevelopmental outcome at age 2 and 5 in relation to BPD severity in 790 infants in born at less than 30 weeks gestational age. The cohort was subdivided according to severity of BPD, and most children did not have BPD. As you can see, from here to the more severe forms of BPD, these infants with higher severity of BPD also had more PDA, NEC, and more often dexamethasone treatment. Both at 2 and at 5 year outcomes were worse the higher the BPD severity. In those with severe BPD, NDI occurred at in 33% of the children at the age of 2 and at 67% of the children born at age 5. However, NDI also occurred in 11% of the children without BPD, and that increased to 40% of the children without BPD at the age of 5. So the increase in NDI rates was higher in those without BPD, but the highest rate remained to be found in those with the most severe forms of BPD. As you can see here, at the age of 5, NDI, CP, an abnormal score on the movement ABC, and an IQ lower than 1 standard deviation below the mean, these rates all increased with higher severity forms of BPD, with only the exception of CP in those with moderate CP, moderate BPD. Our conclusions from this study on BPD outcome at 2 and 5 years were that BPD is associated with neonatal inflammatory and also non-inflammatory risk factors. The higher the grade BPD, the more morbidities. And BPD is also associated with cognitive and motor outcome at age 2 and 5. At age 2, in severe BPD, already 30% had NDI, well, that was 10% in the group without BPD. And at the age of 5, in severe BPD, we found 67% of the children with NDI, while this was 40% in a group without BPD. So you can see the increase rate of 3 versus 1 versus 1.5 versus 1. What are the possible causes of the relation between BPD and NDI? The evidence from the strong relation between BPD and NDI comes not only from the French and our sources, but actually almost any study on risk factors for worse neurodevelopmental in outcome finds that BPD as a factor. First, there are shared causes between BPD and NDI, like IGR, smoking in pregnancy, and chorioamnionitis. And second, there is white matter injury secondary to the hypoxia and the inflammation that is associated with BPD. But also, as we saw in our Dutch study, BPD has an association with other severe neonatal morbidities like PDA, IVA, sepsis, and NEC. And lastly, there is a delayed neonatal unit discharge in those with severe forms of BPD, and there's more often rehospitalizations after the child has first gone home, which also negatively affects outcome. And then, of course, BPD is often asked for corticosteroid therapies. Now let's further dive in those steroid therapies. Because because as we saw before, inflammation here and there is the most important causal factor in the treatment of BPD, it is not surprising that various types and regimens of corticosteroids have been tried in neonatal medicine. Many RCTs were carried out to study the effect of the most potent drug, dexamethasone, on the prevention of BPD. Last year, these trials were meta-analyzed in the Cochrane database. The focus first was on early administered dexamethasone, so in the first 7 days of birth. Also because trials showed positive effects of this administration on death or BPD with a number needed to treat of 16. However, long-term outcomes showed that later on this benefit could be at the cost of worse developmental outcome. And also gastrointestinal perforation more often occurred. The studies that investigated later initiation of dexamethasone may also show positive effects on death or BPD, but the evidence was rated at low certainty. However, no unfavorable balance between benefits and harms was found if dexamethasone was started after the first week of life. But one would expect better outcome if indeed BPD has a direct causal effect on neurodevelopmental outcome. And so far, dexamethasone just decreased BPD, but not improved neurodevelopmental outcome. I now like to discuss hydrocortisone trials in the prevention of BPD. Hydrocortisone came into the picture because dexamethasone was associated with worse long-term outcomes, as I just showed you. There are 3 well-known hydrocortisone trials, all published between 2019 and 2022. The first one used a 10-day tapering course started between day 14 and 28 in intubated extremely preterm infants, the highest risk group for BPD. It had neutral findings on the outcome survival without moderate severe BPD. The second trial is our nationwide Stop BPD trial, starting hydrocortisone somewhat earlier in the same high-risk infants, but also without affecting outcome death or BPD. And the third one used early dose of hydrocortisone in a wider range of preterm infants and found positive outcomes on the survival without BPD. But also reported on higher incidences of late onset sepsis and gastrointestinal perforation. Importantly, none of these 3 studies showed a positive or negative effect of NDI rates at the age of 24 months. Our Dutch-Belgian Stop BP3 trial will be now discussed in somewhat more detail. In that study, 372 infants with a mean gestational age of 26 weeks were included when they were mechanically ventilated between days 7 and 14. And they received a 20-day course of hydrocortisone or placebo. And the primary endpoint was death or BPD, moderate to severe BPD, that is. This endpoint was in these high-risk infants very frequent. It was occurred in 71% in the hydrocortisone group and 74% in the placebo group. And that, of course, was not different between the groups. Currently, we are working on the 5 years follow-up of these high-risk infants. And results were recently presented at the PAS in Hawaii. So, as I told you, we included 372 infants, of whom 94 died. And using the Dutch neonatal follow-up program that runs in all NICU centers in our country, we were able to collect follow-up data in 78% of the children participating in the trial. And follow-up was not planned at start of the trial, but only this resulted from the regular follow-up in our country. Those that were not seen in follow-up, those 22%, differed from the 78 that were seen in follow-up, as is often the case in the lost to follow-up. The 22% that was lost to follow-up had a higher risk on the neurodevelopmental outcome problems because the parental education was lower in these infants. The mothers had smoked more in pregnancy, and at the age of 2 years, there was more neurodevelopmental impairment in those not seen for follow-up at the age of 5. And here are the results, the background characteristics of those seen in follow-up, and we were able to have to see 112 hydrocortisone treated infants and 103 placebo children. And the parental education was similar in both groups, and also all other variables. You can see that they had a very low gestational age of 25.5 weeks, and that their weight was about 795, 740 grams. And they often had moderate to severe BPD, as already known from the overview slide, and that occurred in about 60% in both groups. Only the use of open label steroids differed significantly between our follow-up groups because this occurred twice more often in the placebo group. And here are the outcomes at the age of 5.5. We found that cognitive problems, and we define that as a full-scale IQ below 85 or being in special education, occurred in about 40% in both groups. And by the way, special education was already in place in about 20% in both groups. The most frequent adverse outcome was an abnormal movement ABC score, so you could say developmental coordination disorder that was there in about 50% in both groups. And these neurosensory outcomes, so CP, severe visual loss, and severe hearing loss were infrequent in these infants, and CP occurred in 4 versus 8%. But none of the differences reached statistical significance, and they were all quite similar. What can we conclude from our trial? In children included in our trial, mortality was 25%, and in the survivors, 2/3 had moderate or severe BPD. They also had a high risk of neurodevelopmental disabilities, especially with respect to cognitive and motor disabilities. Hydrocortisone therapy was neither harmful nor beneficial for any of the endpoints. And importantly, because of the high vulnerability of this patient group, the search for effective preventive measures for BPD and also for worse developmental outcomes needs to go on. In the search for treatment that both decreases BPD and improves outcome, the analysis of Doyle CS in JAMA earlier this year is therefore interesting. These authors put together DEXA and hydrocort trials aiming at BPD prevention initiated in or after the first week of life. As shown to you earlier, DEXA is effective in decreasing BPD rates more than hydrocortisone, in which no effect was found. And you can see the number of the participants included in the review here. The analysis of the group of Doyle found that if the BPD rate in the control group is low, so 20 to 40%, these children had a lower rate of CP if treated with placebo compared with those treated with dexamethasone. So if you include children at low risk of BPD, then the final endpoint for all children seems to be worse. But if BPD in the control group increases to more than 50%, they found that dexamethasone was associated with improvements in outcome, that there were lower risks of CP in the dexamethasone group. And a similar thing was not found for hydrocortisone. So there is hope, especially for the CP outcome at 2 years in relation to DEXA treatment, because there is evidence for a positive association between the treatment effect of systemic dexamethasone on survival free of cerebral palsy and the risk of BPD in the control group. For every 10 percentage point increase in the rate of BPD in the control group, the risk difference for survival free of cerebral palsy increased by 3.7%. And there's a suggestion, so that's very carefully stated, of a benefit from hydrocortisone at a low risk of BPD. I'd like to conclude with our nationwide preventive developmental support intervention called TOP. And this research stems from earlier times. In this program, specially trained child physiotherapists visit homes 12 times between discharge and the age of 12 months. This intervention proves especially effective in infants with BPD, So if you can see here, these two groups have BPD, the circles and the squares, and you can see that they have over time, the cognitive outcomes are improved in the children with BPD treated with this postnatal intervention. And the same is true for motor outcome. So this is hopeful. BPD is not a crystallized risk factor for worse neurodevelopmental outcome, but infants with BPD especially need our continued care and interventions once they are home with their parents. So with that, I do hope I have given you an update on BPD and neurodevelopment and would like to thank you for your attention.
Muchas gracias por esta hermosa conferencia, Aleid, y todas las dudas que nos quedan con respecto a qué esperar de nuestros niños con displasia. Pienso que se va cerrando en el niño con la displasia severa. Sobre todo en estos estudios que nos has mostrado, aparentemente es el severo, es el que tiene el compromiso cognitivo. ¿Qué nos puedes decir al respecto?
Yeah, that of course, if you have this the severe case, it is those are the children with the highest rates of hypoxias and of this hyperinflammatory state. So the brain damage in that children is more prevalent, and that's the reason that in later onwards they more often have neurodevelopmental impairment. But it should not be underestimated that the associated the comorbidities do also play a role. So the higher the severity of BPD, the more severe are the comorbidities. So it's really a mix of factors that runs via this severe BPD entity and then subsequently is associated with these worse outcomes.
Hello, Dr. Aleid. Just a quick question. How long do you follow these BPD babies? How many years do you do the follow-up?
I did not address pulmonary outcomes, but we also do lung function in these children at the age of 5 and 8, when it is possible, when the child can cooperate with the lung function test.
Hola. ¿Sí? Yo quería preguntar. ¿Ahora sí? La pregunta tenía que ver con esto, digamos, estos chicos con displasias broncopulmonares, ¿se pudo detectar qué tipo de impacto en el neurodesarrollo, pero no solamente lo cognitivo, sino las habilidades alimentarias, habilidades que tienen que ver con el lenguaje?
No, I just can talk from my personal experience. That mostly in the first year the feeding difficulties occur, but later onwards it really depends on behavioral problems of the children. But there are many children that have normal feeding practices when they grow up as at school age. And I must say, in this RCT, we are still working on use of all other interventions and the care systems, and maybe we can pick up something via the use of extra help or special diets, but that's work in progress.
Hay una última pregunta que queremos hacerle.
¿La oíste?
Es que hay un delay en la traducción.
Um,
La siguiente pregunta, y va a ser la
So.
última para que le comuniques, es si acaso realizan rehabilitación después del diagnóstico de función pulmonar entre los 6 y los 8 años. ¿Hacen rehabilitación respiratoria y hasta cuándo?
What we really, we try to improve lung function with medication if needed. And sometimes we find that parents are not aware of the decreased lung function of their children. So they participate less in sports and are less active. So once we have improved with medication the pulmonary function, we try to facilitate the children to participate in sports. But that is something that we advise in a clinic, and I don't have data on whether that the parents really go by our advice and really go with our children to the sports. But that is a topic of our follow-up, sports participation.
Ok, ella contestó la pregunta que se le hizo. Puedes decirle que estamos felices con su participación y bueno, seguiremos contando con ella y muchísimas gracias por todo lo que nos ha enseñado. Muchas gracias.
Thanks.